Okay, let's unpack this. We're doing a deep dive today into how we try to understand and categorize mental health conditions.
Hmm.
Specifically, we're zooming in on obsessive compulsive disorder, OCD, and its complicated relationship with anxiety disorders.
And guiding us through this is a really interesting academic paper. It's called Seeing Beyond the Diagnostic and Statistical Manual, a function-centered review of obsessive compulsive disorder and anxiety disorders.
Okay.
It's by John Inge Hlensen, Jan Bergstrom, and Per Carl Bring. And it's just been accepted for the Journal of Obsessive Compulsive and Related Disorders.
So this isn't just a summary then. It sounds like it's making a case, challenging
Oh,
things.
absolutely. It's basically saying, hold on a minute. The standard manual of the DSM-5, it moved OCD out of the anxiety disorders chapter into its own little group.
Right.
This paper argues, maybe that wasn't the best move,
So what's their core mission with this paper? Reclassify it.
pretty much. They want to show that even though it's classified separately now, in practice, and based on how the symptoms function, OCD looks a lot more like an anxiety disorder.
Hmm.
They go through the reasons given for separating, things about brain differences or symptom presentation, and basically say the evidence just isn't strong enough.
And I guess this matters, right? It's not just academics debating
Oh, no
categories.
way. It affects everything. How we think about these conditions, how research is funded and focused, and crucially, how treatment is approached.
Yeah.
The paper even suggests this separation might have actually slowed down progress in understanding and treating OCD effectively.
Wow. Okay, that is a big claim. Let's back up a bit then. How is OCD classified right now officially?
So yeah, DSM-5 put in this chapter called Obsessive Compulsive and Related Disorders,
Yeah.
OCRDs for short,
Okay.
completely separate from the anxiety disorders chapter, which has, your specific phobias, panic disorder, GAD, things like that.
Right.
It's worth mentioning other systems like the ICD-11 sometimes handle related things, like health anxiety, a bit differently. Sometimes it's near OCD, sometimes not. It's messy.
And just quickly, remind us, what is OCD at its core?
Sure. It's got two main parts. Obsessions.
Mm.
These are unwanted intrusive thoughts, images, urges that pop into your head and cause a lot of distress or anxiety.
Okay.
And compulsions.
Mm.
Repetitive behaviors, or even mental acts, like counting or praying silently that someone feels driven to do, usually to try and neutralize the obsession or prevent something bad from happening.
Got it. And it's pretty common.
Yeah. Affects maybe 1 to almost 2% of people worldwide. So, not rare.
And how do we typically treat it? What's the standard approach?
The gold standard is still cognitive behavioral therapy, or CBT, specifically a type called exposure and response prevention, ERP.
Right, ERP. Facing the fears without doing the ritual.
Exactly. You gradually expose yourself to the feared situation or thought and resist the urge to do the compulsion. What's really telling, and something the paper points out,
Yeah.
is that the main clinical guidelines for OCD treatment, like the NICE guidelines in the UK, they haven't really fundamentally changed since 2005.
2005, that's well before the DSM-5 made that change, right?
Way before. So the diagnostic manual changed its structure, created this new category, but the go-to evidence-based treatment remained anchored in those same anxiety-focused principles.
Okay, that seems significant. That discrepancy gets right to the heart of the paper's argument then, why they think OCD belongs back with anxiety disorders.
It really does. Their main point is that, look, whatever the DSM says, clinicians are still largely treating OCD using models and techniques that were developed for anxiety.
Hmm.
And they argue there just isn't enough compelling evidence of really fundamental differences to justify kicking OCD out on its own. The key they keep coming back to is function.
Function. What do they mean by that specifically?
They mean focusing on the purpose a behavior serves for the individual. Why are they doing it? What outcome are they trying to achieve or avoid? And when you look at it that way, they argue the stuff people do in OCD, the compulsions, the avoidance, it operates on the same basic psychological machinery as the behaviors you see in anxiety disorders.
Like what kind of machinery?
Well, the big ones are, first, overestimating how likely and how terrible a perceived threat is.
Right. Thinking the worst will definitely happen.
Exactly. And second, engaging in behaviors to avoid that threat or to feel safer. Safety behaviors.
Okay.
These behaviors give you temporary relief. Phew, dodged that bullet. But the problem is they stop you from ever learning that the bullet wasn't actually coming or that you could handle it. They block fear extinction.
So it's not just that someone with contamination fears washes their hands, it's why to stop the catastrophic fear from happening, and that why is the same as someone with agoraphobia avoiding a crowd.
That's precisely their point. They call it functional equivalence. The job the behavior is doing trying to increase safety, reduce fear, is the same, even if content is totally different. Contamination versus, say, public speaking.
Yeah.
Think contamination OCD again. Attention locks onto the dirty object. Fear spikes. You wash your hands. Function. Escape the fear. Prevent illness. That escape function, they argue, is identical to someone fleeing a situation where they fear a panic attack.
They use that word devious to describe these safety behaviors.
They do. And it fits, in a way, because they trick you. They work short term, so you keep doing them. But because you keep doing them, you never find out what would really happen if you stopped.
Right. You never get the chance to disprove the fear.
Never. And that locks the whole cycle in place, whether it's washing, checking, avoiding, seeking reassurance.
Yeah.
It's all serving that same devious function.
Okay, so if function is the key argument for putting OCD back with anxiety, what about the category it got moved into, this OCRD group? What was the logic there, and what does the paper say about it?
Well, the logic for creating the OCRD category, putting OCD with things like body dysmorphic disorder, hoarding, hair pulling, skin picking, was based more on surface similarities.
Like intrusive thoughts and repetitive behaviors?
Exactly. They look similar in some ways. But the paper's counterargument is, just because things look alike doesn't mean they work the same way underneath. Description isn't function.
So scratching the surface reveals differences.
That's what they argue. Take hair pulling or skin picking. Often there aren't those classic, intrusive, anxiety-provoking obsessions driving them. The pulling or picking might not even be primarily about reducing anxiety. Sometimes it's automatic. Sometimes it might even feel soothing or satisfying briefly. Very different function than a compulsion to ward off disaster.
Okay, so pulling hair doesn't serve the same desperate prevent catastrophe function as, say, checking the stove repeatedly.
Right, or hoarding disorder. People hoard, yes, and have thoughts about items, but those thoughts usually aren't experienced as intrusive or ego dystonic, alien and horrible in the way OCD obsessions are. The distress is often more about potentially losing items. Different flavor, different function.
But what about body dysmorphic disorder, BDD? That seems closer.
Good point. And the paper agrees. BDD does seem to share more functional overlap. You have intrusive, distressing preoccupations about perceived appearance flaws. That sounds like obsessions.
Yeah.
And the repetitive behaviors, checking mirrors, comparing, are often done specifically to try and reduce that intense anxiety or distress. Functionally, that looks a lot like OCD and anxiety.
So the paper's critique of this whole OCRD category is that it's a bit of a mixed bag, functionally speaking, grouped by appearance, not necessarily by underlying mechanism.
Precisely. It questions whether grouping based just on description was the most helpful move, especially if it obscures these important functional similarities and differences. It makes you wonder if BDD might actually fit better alongside OCD and anxiety than with, say, hair pulling.
Okay. Let's really hammer home this functional equivalence idea. The paper compares OCD to specific anxiety disorders, right?
Yeah.
How does it look side by side? Let's start with something straightforward, like a specific phobia.
Sure. Specific phobia, intense fear of spiders, heights, flying, whatever, leads to immediate fear response, strong urge to avoid. Right. The functional parallel the paper draws is crystal clear. Stimulus, spider doorknob, triggers fear. Behavior, run away, wash hands, aims to escape fear and prevent the feared outcome, getting contaminated. The intention, as one researcher put it, is identical. Avert catastrophe.
Makes sense.
Yeah.
What about panic disorder? Those out-of-the-blue attacks?
Well, panic attacks themselves can happen in OCD too. They're not exclusive. But looking at panic disorder itself, often driven by misinterpreting body sensations catastrophically.
Yeah.
Shared cognitive biases pop up again.
Yep.
Overestimating danger, feeling vulnerable, needing control. And the safety behaviors look functionally the same. Avoiding exercise because you fear it'll trigger a panic attack reinforces the belief exercise is dangerous. Avoiding a contaminated surface reinforces the belief touching it would cause disaster. Same function. Prevent perceived danger.
Okay. Agoraphobia. Fear of being trapped, can't escape.
Fits the mold perfectly. Fear of public transport, crowds. Overestimating the threat, underestimating your ability to cope. So what do? Safety behaviors. Bring a friend for reassurance, only go to familiar places. Functionally, that friend is like the compulsive checking in OCD trying to guarantee safety. Avoiding the bus is like avoiding the public restroom. Fear, avoidance, function.
Social anxiety disorder, SAD, fear of judgment.
Yep. Cognitive model there is fearing negative evaluation, thinking you'll act ineptly, leading to rejection.
Okay.
So you engage in safety behaviors, rehearse conversations endlessly, avoid eye contact, speak quietly. These aim to prevent the feared social catastrophe. The paper notes that treatment for SAD exposure, dropping safety behaviors, is basically the same template as ERP for OCD.
Huh. Even the mental imagery.
Yeah, they cite research suggesting the kind of intrusive, dreaded imagery people experience in OCD isn't fundamentally different from SAD. Visualizing contamination versus visualizing being humiliated, it's functionally similar, anticipating a feared outcome. Both are maintained by these dysfunctional beliefs and avoidance patterns.
Generalized anxiety disorder, GAD, the constant worriers.
GAD worry is often described as less bizarre or intrusive than OCD obsessions, maybe more focused on real-life concerns, but taken to an extreme.
Right.
But again, shared features. Safety seeking, like excessive planning, inflated sense of responsibility, needing lots of reassurance. That inflated responsibility idea is interesting.
Yeah.
Maybe it focuses more on external events in GAD versus internal thoughts in OCD. But the paper suggests that underlying mechanism might be transdiagnostic anyway. The core pattern holds: inflated responsibility, catastrophic beliefs, safety behaviors.
And health anxiety. Fear of illness. This
Yeah.
one gets classified weirdly sometimes.
Exactly. DSM puts it under somatic symptom disorders. ICD puts it near OCD. But the paper argues strongly. Functionally, it looks just like OCD and anxiety.
How so?
Persistent fear of serious illness, repetitive behaviors like body checking, Googling symptoms, seeking reassurance from doctors or family, or avoiding hospitals, avoiding health information. It maps perfectly onto that cognitive model. Overestimating the threat of normal bodily sensations, underestimating your health or ability to cope, engaging in behaviors to reduce anxiety or prevent perceived illness, intrusive thoughts about dying, check. Treatment with ERP-like approaches, check. Functionally, it fits.
Lastly, PTSD. Also moved out of anxiety in DSM-5, like OCD.
Yeah, PTSD is definitely complex, often involves trauma-specific elements, but the paper points out functional parallels again.
Such as?
Intrusive memories acting like obsessions. Active avoidance of reminders, places, thoughts, feelings, that's like avoidance and phobias or OCD. Repetitive behaviors or mental acts to reduce distress. Cognitive biases like feeling responsible for the trauma. The content differs. PTSD, anxiety, is often about the past re-emerging now. OCD is often about preventing a future threat. But the function of the avoidance and safety strategies, trying to control thoughts, reduce distress, stay safe, looks remarkably similar.
Okay, wow. So looking across all these disorders through that functional lens really does highlight profound similarities with OCD, which makes a DSM-5 decision to separate it seem questionable based on this paper's argument.
Exactly.
So what was the official reasoning for separating OCD, and how does the paper dismantle it?
The stated goals for the DSM-5 move were, laudable sounding, improve validity by reflecting underlying biology better, improve clinical utility for assessment and treatment. The main arguments hinged on supposed differences in neurobiology and phenomenology.
Okay, let's take the neurobiology first, the brain stuff.
Right. Early on, there were suggestions of key differences, like maybe the amygdala, the fear center, was less reactive in OCD compared to, say, social anxiety, where it's thought to be hyper-reactive.
And the paper says?
It says newer research paints a more complex picture. Actually, the amygdala is involved in OCD's emotional responses, maybe even overactive sometimes, depending on the context. So that clean distinction didn't really hold up.
What about those specific brain circuits often linked to OCD, the frontostriatal loops?
Yes, exactly. Hyperactivity in areas like the orbital frontal cortex, the anterior cingulate cortex, the striatum involved in habits, errors, rewards. This was flagged as potentially unique to OCD.
Okay.
The paper acknowledges findings there, but points to newer meta-analyses suggesting it's probably not just those circuits. It might be broader, large-scale network dysfunction. And honestly, they argue our current brain imaging tools might not be precise enough yet to draw these really sharp diagnostic lines based on brain activity alone. Plus, they cite critiques saying basing classification purely on brain data right now is maybe premature.
What about medication responses, like OCD needing higher SSRI doses?
They mention that, yeah.
Yeah.
But their critique of relying on pharmacology is broader. They argue that a purely biological framework tends to ignore the psychology, the meaning, the function, the learning.
Right.
It risks reducing the condition to just brain chemistry, pushing psychological therapies to the side, and focusing research on internal variables that might not be the most helpful levers for change compared to understanding the person's behavior and their environment.
Okay, a strong challenge to the biological rationale. What about the phenomenology argument that the experience or symptoms of OCD are just fundamentally different?
The core argument there was something like, in OCD, anxiety is a result of the obsessions and compulsions,
Mm.
whereas in anxiety disorders, anxiety is kind of the main primary thing itself.
Hmm. How does the paper counter that?
They go right back to the definition. What is an obsession? Per the APA's own definition, it's an unwanted thought image causing fear or anxiety.
Ah,
So anxiety is baked into the definition of the trigger itself. Then they flip it. If someone with social anxiety has a persistent, intrusive, unwanted fear of humiliation, isn't that functionally like an obsession? If they use excessive preparation or avoidance to manage that fear, isn't that functionally like a compulsion?
so they're saying the definitions themselves, if applied functionally, could blur those lines considerably.
Exactly. They argue that when you look past the surface content, the core experience, excessive fear, anxious worry, avoidance aimed at reducing distress, is fundamentally shared across OCD and anxiety disorders. The phenomenological distinction isn't as clear-cut as suggested.
So the paper keeps circling back to function because the arguments used for separation neurobiology, phenomenology just don't seem strong enough or maybe relevant enough compared to the shared functional mechanisms.
That's the core message.
Yeah.
They champion the cognitive models, Clark, Tsiolkovsky's, Wells, precisely because these models focus on those functional processes. Threat appraisal, safety behaviors, attentional biases, inhibited learning. And these models have led to effective treatments across these disorders, despite any underlying neurological nuances.
And you mentioned transdiagnostic approaches supporting this.
Yes.
Yeah.
Things like repetitive negative thinking, just chewing on negative thoughts that's seen across OCD, anxiety, depression. It's not specific. Or vulnerabilities like anxiety sensitivity, being afraid of anxiety symptoms themselves, that interacts with disgust sensitivity to predict contamination OCD. It fits broader models that see these conditions sharing common roots, like Barlow's triple vulnerability idea.
So the evidence points towards shared vulnerabilities, shared functional patterns, and treatments that target these shared patterns seem to work.
Precisely. And the paper makes a really pragmatic point. Practicing clinicians rely on functional analysis day to day. They ask, why is this person doing this? What function does it serve? They don't typically base their therapy plan on intricate brain scan results.
Right.
They argue that shifting the focus away from function towards potentially shaky biological distinctions in the DSM-5 might have inadvertently slowed things down, theoretically and clinically, for OCD over the last decade or so.
That's quite the indictment. Misclassification potentially harming progress. So what are the big takeaways here? What are the implications moving forward?
Well, first, they absolutely acknowledge that treatments like CBT and ERP do work for OCD. They're evidence-based.
Right.
And there are cool innovations happening in delivery. Things like using VR or AR for exposure therapy, internet-delivered CBT, which can be really effective and scalable.
But there's a but.
The big but is access and engagement. We have treatments that work, but huge numbers of people don't get them. Cost, stigma, availability, just not knowing where to turn. Maybe only 30–40% of Western countries actually seek help. That's a massive treatment gap.
And the paper links this back to the classification issue.
They sort of lament the lack of major breakthroughs in treatment efficacy or novel approaches over the last 2 decades. They pose the question, did focusing on separating OCD, perhaps based on flawed or incomplete reasoning, divert attention and resources away from refining treatments based on those core functional principles shared with anxiety?
So the message about diagnostic manuals like the DSM is?
That labels are useful, but they're not enough. A diagnosis tells you what cluster of symptoms someone has, but it doesn't tell you why they're stuck or how to help them change. You need that complementary layer of theory-driven case conceptualization grounded in functional analysis.
Understand the individual cycle, not just the label.
Exactly. Understand the maintaining factors.
And their final word seems like a warning, almost.
It does. It's a strong call not to chase neurobiological trends at the expense of the solid, proven foundations of CBT that come from understanding function. They argue that sticking with a potentially flawed classification risks further stagnation, and ultimately that doesn't serve patients well.
You know, what's striking about this whole deep dive is how it shows that these classifications we create, they're not just neat boxes, they have real consequences. If, as this paper strongly argues, separating OCD hasn't really led to better treatments or wider access over 20 years, well, it makes you question the value of that particular classification.
It really pushes us to ask, what's more important for actually helping people? Refining descriptive labels based on biology that might not be fully understood yet, or doubling down on understanding the function of someone's struggles within the context of their life.
So, the provocative thought to leave you with today is this. If our current way of labeling mental health difficulties hasn't necessarily revolutionized treatment outcomes, especially for something like OCD, what happens if we shift our focus? How might thinking more about the function of distress, what purpose do these difficult thoughts, feelings, or behaviors serve, even if maladaptive, change how you understand these challenges, maybe in yourself or in the people around you? Something to really mull over.